You are attending the Washington Telebuprenorphine Hotline statewide launch webinar today. So glad you are all here on a Monday afternoon. I'm Renee Tinder, and I'm a behavioral health strategist here at the Department of Health, and I manage this contract and work with this wonderful team of folks at the University of Washington Department of Medicine. I'm going to go ahead and just do a little bit of housekeeping for Zoom today. So if in the chat, if you want to go ahead and enter your name, your agency or organization, and your role, that would be great. If you have any questions about the logistics of the webinar, please enter them in the chat. We have staff that are monitoring the chat for any, like if you can't hear or if you can't see our speakers spotlighted or the interpreter, please let us know in the chat. For any questions you have for our panelists, please enter those in the Q&A section. We will be taking some time at the end of the presentation to go over all of those questions. So we want to make sure they're all captured in the Q&A. So if you can just put them there instead of the chat, that would be great. And then in order to have, excuse me, closed captions enabled, you can click on that closed caption button at the bottom of your screen. Okay, I'm going to go ahead and turn it over to Dr. Tao Quandet, our State Health Officer, and he's going to kick off the webinar. Go ahead, Tao.
Thank you so much, Renee, and good afternoon, everybody. And thank you for the opportunity to say a few words on this momentous day for public health in Washington. Next slide, please. So 2 years ago, UW Medicine and Public Health Seattle King County started the telebuprenorphine hotline, fondly known as Telebup, giving people in King County with opioid use disorder the opportunity to use telehealth to start buprenorphine, which is a medication that eases opioid withdrawal symptoms. Offering this service gives hope to individuals and families desperate to recover their lives from the grip of opioid addiction, and the program has been incredibly successful. And last year, with funding from opioid settlement dollars and support from the Washington Department of Health, the program was expanded last fall, first to the Olympic Peninsula, and then to several counties in central and northeast Washington. And the next slide, please. And with today's launch, Telebup now covers the entire state, giving people with opioid use disorder access to treatment no matter where they live in Washington. Next slide, please. And this comes at not a moment too soon, at a time when drug overdose deaths are higher in Washington than in the United States as a whole. And as you can see, the black line representing Washington is coming down in this graph, but while it's hopeful, it's far too early to say that we have turned the corner in terms of opioid deaths in our state. More than 3,000 people lost their lives to overdose in 2024 in Washington, and the numbers in 2025 are still being analyzed, but I know that there were times in 2025 when year-to-date deaths were greater in 2025 than in 2024. So now is definitely not the time to let up, but to continue to press on with our state's response to the opioid and overdose crisis. Next slide, please. Treatment medications like buprenorphine are the most effective tools we have to prevent overdose among those with opioid use disorder. And that's why increasing access to medications for opioid use disorder is a top priority of our state's opioid and overdose response plan. Expanding Telebup statewide is an important step that will make it easier for those with opioid use disorder to start buprenorphine no matter where they live in Washington. This will definitely save lives. But at the same time we celebrate the statewide expansion of this incredible program, we also have to recognize all the work that remains to be done. We need to increase the availability of treatment across the continuum of care for opioid use disorder and support people in recovery and when they relapse. We need to expand our harm reduction efforts, including distributing naloxone to those at highest risk of overdose. We need to continue to educate and communicate and reduce the stigma that so many people with opioid use disorder suffer, stigma that makes it more difficult for them to get the care they need. And we need to strengthen and expand our upstream prevention efforts, starting in the earliest stages of the life course to prevent opioid use disorder from occurring in the first place. Next slide, please. I hope that at this time next year, we'll be able to present numbers and graphs that show overdose deaths clearly on the decline, and that would be incredible. And I know that the Telebup hotline will have a lot to do with that. But for me, just as powerful as numbers and graphs are people's words and stories. And here are some quotes from people whose lives have been changed for the better by Telebup. There's a quote from a person who owes their success and recovery to Telebup. Another who thought Telebup sounded too good to be true. And the quote on the right from a person who credits the hotline with saving them from relapse. And while we can't say for sure that we'll have better numbers next year, I'm absolutely 100% certain that a year from now we'll have more stories and more quotes of paths that have been altered and lives that have been transformed for the better thanks to the telebuprenorphine hotline. So to all of you who have been involved in this effort, thank you. These words and stories are a testament to your work as care providers, as coordinators, as communicators, as administrators, as supporters, and advocates. Your work is saving lives and will continue to save even more lives in the coming years. Next slide, please. So on behalf of everybody at the Department of Health, thank you to UW-Medicine and Public Health in Seattle-King County for starting Telebup 2 years ago and growing it to be the statewide source of hope for people throughout Washington that it is today. I also want to express my thanks to the teams at the Department of Health who have helped facilitate this expansion. Like so many success stories in public health, the story of Telebup is one of collaboration, care, and compassion. And it's now my pleasure to turn things over to the UW team to tell you more about this remarkable program. Thanks.
Thank you so much. Thank you for that kind introduction, and thanks to all of you for joining this webinar and hearing what we have to say. And our hope is that this webinar will help us partner with you and your organization so that we can care for patients in your communities. My name is Lauren Whiteside, and I'm here on behalf of the University of Washington Department of Emergency Medicine team, who's been working so closely with partners, as Dr. Kwan-Get mentioned, at Department of Health, as well as Seattle-King County Public Health. And I will be doing this presentation with Olivia Hood, who is our program manager, as well as Chris Baresh, who is a co-medical director alongside with myself for the program. Next slide. As Dr. Kwan-Get mentioned, we are still in the throes of an opioid crisis, and this slide here depicts the drug overdose death rates by county in our state. And you can see here that there's really no county that has been spared this public health problem and this epidemic. We do know, based on the prior data that was shown, that there is some hope, and it appears that we are in a downslide. But such a big part of the solution to this problem is multifaceted and is getting community organizations together to tackle this problem in multiple ways. In the slide here, you can see that counties that have the highest population adjusted rate of fatal overdose are depicted in that really dark blue color. And again, there's really no area in our state that is spared from this problem. Go ahead, next slide. So what we are offering today is an opportunity to expand our program, which we call Telebup, and offer this evidence-based treatment to everybody across the state. Buprenorphine for opioid use disorder is an evidence-based solution, an evidence-based treatment to the medical problem of opioid use disorder. We know that there is a lot of evidence that buprenorphine, which we also sometimes call Bup for short, or the trade name for that is called Suboxone, has a lot of evidence and that it improves people's lives. And in the green column here that is labeled buprenorphine and methadone, those two medications have a lot of evidence that they can reduce opioid-related mortality, and they reduce all-cause mortality. We also know that patients that are on these medications have improved quality of life and use less illicit opioids. So not only does medications for opioid use disorder keep people alive, but it keeps them healthy, it keeps them well, and it keeps them engaged in their communities. So this program, Telebup, provides a way to improve access to this life-saving medication for everyone across the state. Go ahead, next slide. One of the things that we really strive for is making sure that this treatment, buprenorphine or Bupe, is available at the moment that people are ready. This medication, this program will allow us to ensure that it is low barrier, meaning that when people are ready, all they have to do is pick up the phone, call us, and we can help reduce barriers and make sure they get seen as quickly as possible. The visit is free. This program is funded through this partnership through the Department of Health, so we're not going to be billing insurance for the clinical visit, and patients don't have to worry about insurance barriers for this service. In our program, we have embedded regional support, taking advantage of champions in community that are embedded and live within everybody's specific community so that we can really try to understand how to improve care and link patients to ongoing care in the place with which they live. And we're also going to strive for minimal wait time. So we're going to be on demand. So as soon as patients are ready, we will be available for them. And with that, I'm going to hand this over to Olivia Hood, the program manager for this program, to talk more about the details.
Hello, everyone. Lauren, thank you so much for that introduction and starting us off. My name is Olivia Hood. I have been with the Telebupe program since we started in 2024 and have the pleasure to serve as the program director. I would like to talk to you today about what the Telebupe hotline can look like for those in your community and yourself as a healthcare provider. So let's go through the Hotline 101. First, we are open 7 days a week from 9 a.m. to 9 p.m. With that, we serve patients all across the state of Washington as of today who are 13 years and older and seeking buprenorphine for the treatment of opioid use disorder. I call that out because we cannot treat for solely chronic pain or isolated kratom use disorder through the hotline, and we are very much focused on opioid use disorder for this service. With that being said, we are staffed by a team of exceptional 14 emergency medicine physicians, all from UW Medicine. These doctors are trained in unobserved buprenorphine starts and have staffed this hotline since January 2nd of 2024. Along with that, we have one physician on call every day. So you will have the same doctor throughout 9 a.m. to 9 p.m. when you call in to help with any pharmacy issues or questions that you may have after that initial telehealth visit. Similarly, we have a wonderful team of 6 linkage to care coordinators that are really the heart and soul of this Telebupe hotline and why it works and is effective for patients in our community. These coordinators are handling the intake calls when patients call into the hotline to ensure you're a good fit for our providers, and then also going above and beyond after that first visit to ensure that you're able to link to care in your community for ongoing MOUD. We will continue expanding our team throughout the end of 2026, but what we will introduce to you all today is coordinators that are also regional based and living within the ACH region to really be boots on the ground experts for the care continuum for patients. Next slide, please. So how did we get here today? As you've heard earlier in this presentation, we had a partnership with Public Health Seattle-King County to create a pilot program to see if this was successful. And that is where Telebupe started on January 2nd, 2024. We're grateful that we had wonderful success to serve our patients in the first year, which is where we started having conversations with Department of Health of how can we bring this service to the entire state of Washington. We began a contract with them on July 1st of 2025 and started our first phase of expansion in October of last year. The second phase of expansion started in November, and I'm very proud to say as of today, we are officially launched throughout the entire state of Washington. Next slide, please. Okay, so how does the hotline actually work for yourself, for your patients, for your community members? Well, whether you're a patient, a caseworker, a social worker, or family and friend, you can call into the hotline. You're first going to get one of those linkage to care coordinators to answer some questions for you. We have several different queues that you can be put in, one being an intake queue, another being an EMS queue. So if EMS providers are calling into the hotline, we always ensure that they're triaged first and foremost to ensure timely care for those patients, and a line for pharmacy questions as well. Our coordinator is going to ask a handful of questions. First, are you in the state of Washington? Are you 13 years and older? Are you calling for buprenorphine for opioid use disorder? If all of that is yes, then we're going to gather some demographic information from you, your first and last name, your date of birth, a callback phone number, and your address. If you do not have a set address, that is completely okay. We have many patients who are unhoused through the hotline. The address is required for an e-prescription to be sent. However, if you don't have a stable address, we will find an address to put down in your community to ensure that that prescription still goes through. At that point, we have an option for an audio or video visit through the hotline. The audio visit is a live transfer to our provider or a phone call back. The video visit is all done through Zoom, which is a HIPAA compliant platform. At that point, we'll also gather your preferred pharmacy and insurance basics. As Lauren said, we are not billing for insurance. This service is completely free. However, the medication is still the patient's responsibility when they get to the pharmacy, and we do everything in our power to lower any barriers that the patient may experience there. So we like to know what insurance you have to understand what barriers you might experience or what medications you specifically need that we know your insurance covers. After all that happens, our average turnaround time between the intake call and provider visit is 13 minutes. At that point, you'll either hop on a phone call with the provider or join the Zoom room. That provider visit, on average, takes 20 minutes. It can be a little shorter or a little longer, depending on if this is the first time a person has been on buprenorphine before. Everything is documented with an Epic, and then all buprenorphine and ancillary medications are sent to the patient's preferred pharmacy. At 72 hours, our linkage to care team is starting to follow up with patients. They're addressing any barriers that they had to picking up the medication, ensuring that they feel well after they've started it, and then assessing linkage to care options. We look at both in-person and telehealth options to connect them to care, and we'll continue following up with them until they have taken that next step in their recovery journey. After hours at 9 p.m., when the hotline closes, you have two options. You can leave a voicemail and request a call back for us the next day when clinic opens at 9 a.m. Or if you need overnight crisis support, you can be transferred over to the Washington Recovery Helpline. Next slide, please. Wonderful. So the linkage to care part, this is really the heart and soul of Telebup and why it works. So what happens after that first visit? Well, first, if you've reported that you had a recent overdose in your telehealth visit, we will not wait until 72 hours to check on you. We're actually checking on you at 24, 48, and 72 hours to ensure that you're doing well, and we'll provide you with additional resources. For insurance, if you do not have insurance coverage or uninsured, we can provide GoodRx or ArrayRx coupons to help lower that medication cost. We'll also provide information to sign up for insurance, give you the Apple Health Access number, and because we're a UW Medicine program, we also have access to the UW Financial Assistance line. Transportation, many of our patients do have transportation barriers, so we're often mapping out public transport routes for them or connecting patients to Medicaid and Medicare transport. For healthcare, we do a variety of referrals. So we don't just care if a patient is continuing on with their buprenorphine. We care about their whole person care for their next steps in their recovery journey. Because of that, we will do MOUD referrals for medications for opioid use disorder. We will also do primary care referrals, behavioral health referrals, and sexual health referrals if you would like. For basic needs, we also try to provide patients with access and information tied to food banks, clothing assistance, day centers, and community resources, as well as family support resources, which is especially important for our youth patients that come in through the hotline. Next slide, please. Wonderful. And the people that make all of this happen, our Linkage to Care team, I would like to introduce. I will ask those that are here with us today to please jump in the chat and introduce themselves. You will also get their email addresses to be able to reach out to them later in this presentation. Meg Floor is our lead Linkage to Care coordinator across the entire state. McKenna Bixby is our Linkage to Care coordinator for Healthier Here region. Same with Chelsea Lessing, who is our Healthier Here Linkage to Care coordinator. Chelsea is also the one that covers weekends on the hotline for intake as well. And then we have Kayla Moontree Stewart, who just started last week with the hotline, and we are so happy to have her. She is the coordinator for Olympic Community of Health and Choice. And then Tracy Drowns, her first day on the hotline is actually today, and she is covering the Thriving Together North Central Washington and Better Health Together regions. We will have coordinators coming live throughout this year for the North Sound, Greater Health Now, Swatch, and Elevate Health regions as well. Next slide, please. And I will pass it over at this point to my colleague, Chris. Thank you.
Hi, everybody. My name is Chris Burish. I am an emergency physician and a pediatrician, and with Lauren, I'm lucky enough to be one of the co-medical directors of this effort, and it's been amazing. I want to talk a little bit about just kind of broad strokes, some of the things that the hotline can do, and what we can't do, and a little bit more about what kind of medication support people can expect. And so we really try hard not to be the kind of primary care provider or the primary addiction medicine provider for people because we're ER docs. We are not addiction medicine docs, most of us. And so, the idea is that we kind of are there for people when they need it. We are sort of the entryway into treatment or the safety net if they're kind of falling through the cracks. And then we hand them off to somebody that can provide them with ongoing care and kind of dial in their dose and their medication as they need to. As Olivia had mentioned earlier, we don't do chronic pain because that is a very, very complicated thing to do and really needs, I think, an in-person kind of visit to do a good assessment. And we also just haven't done 7-OH or kratom with buprenorphine because I think that the evidence for that is still kind of shaky. And what we don't want to do is have somebody hooked on kratom and then also have them addicted to buprenorphine. So, but we can refer to people that do that and that have a lot of expertise in that. Similarly, if people have chronic pain, our linkage care coordinators are amazing at finding them folks in their community that can help them out with those things. Obviously, it's very difficult to give people injections over the telephone, and so we don't do injectable medications. Subutex is also something that we can't really do because it usually requires a kind of lengthy pre-approval or prior authorization process. And so we can do the combination product, the buprenorphine naloxone, and then again, that buys them time to get a provider that can provide one of those other services, and our linkage to care coordinators will know where those are in people's communities if they're interested in the long-acting injectables. Unfortunately, we don't have the funding to cover the cost of medication. I was actually almost late for this because I was just on the phone with somebody who was getting off a bus in one of the counties north of here, and they were getting off the bus to apply for insurance after having just gotten out of treatment. And we were able to provide them with a GoodRx coupon by text that really cut down the cost of medication while they're waiting for their insurance application to go through. And so, and we have some other kind of limited vouchers that we can use as well. We also can't prescribe to somebody while they're under the care of another physician. And so if they're an inpatient or admitted to a facility where there's a physician, we really can't prescribe to them. And so there are some exceptions to that for people that are, say, in residential treatment where there's no physician coverage. Sometimes we can work with those folks if there's been a pre-existing sort of arrangement made. And so that's not an absolute, but generally speaking, if someone's under the care of another physician, we're not allowed to step in, which is good. You don't want too many cooks in the kitchen. Can we go to the next slide, please? All right. So Our philosophy for starting buprenorphine is really to use this kind of high dose start. There's lots of ways of starting buprenorphine that you or your clients or patients might have heard of with these kind of low dose up titrations and sort of more traditional sort of starts. But this high dose start seems to be the way that works the best for most people and is really amenable to being done in a telehealth situation. It's fairly straightforward, but the downside to the high dose start is that people have to wait until they're feeling pretty sick before they start their buprenorphine. They have to go into some withdrawal before they start their buprenorphine. If they start it too soon, if they start it while they still have, say, fentanyl in their system, it can put them into precipitated withdrawal, which is horrible, and we don't want to do that to anybody. And so what we do is, even though if we say, hey, look, you just used recently, you can't start your buprenorphine right now. We ask them, when you have withdrawal, what are the symptoms that bother you the most, right? Is it nausea? Is it the restlessness? Is it the body aches? Is it the crampy belly pain? And we have medications for those. And so we can give people medications that they can use to kind of mitigate their symptoms and to feel better while they're waiting for the 24-hour mark to start their buprenorphine in a way that will make it more effective and more safe. And that seems to work pretty well for our patients. Next slide, please. And it's been working well. So far, we've had nearly 1,300 patients now that have been seen over the course of about 1,800 visits. And so we have a fair number of people that we see more than once. And we've just had a few come back actually this week from our very first week of being in process. And so, which is really amazing, right? They saw us 2 years ago, they started on the buprenorphine, and then, because of the holidays or whatever, they weren't able to pick up a prescription, and they can call us for a bridge prescription, and they're still doing really well. The stories, Olivia's got so many stories about patients who have had their lives changed for that with this medication. And you only really have to hear one or two of them to really become a believer. And just as a sidebar, I would say that looking at the list of attendees here, I think we know a lot of you. And I want to just say that I know that you're all believers as well. And I want to just take a second to thank you for the work that you're doing. The people that I know that are on this list, I've always found to be really inspiring. And so thanks for doing the work that you're doing, and thanks for being here. Getting back on script, about a third of our patients here come to us for a bridge prescription because there's been some sort of gap. For one reason or another, they blew a tire or whatever. And so we've, kept them from kind of falling through the cracks. A little over 60% were new patients that were provided linkage to care. And even though we see a lot of people that don't have stable phone numbers or stable addresses, there's still very few that are lost to follow up. So I think with that, I will turn it back over to Olivia to kind of bring us home. Oh, no, sorry, I have one more slide. Could we go to the next one? And so even though today really marks our first day of being statewide, today is the ribbon cutting ceremony. We have been working kind of statewide for a while. We have been, we don't turn anybody away in the state of Washington, and we have been able to, get to really every corner of the state. So far, there's still some regions, if you think about that map that Lauren showed at the beginning, where the dark blue regions are, we haven't penetrated those regions to the degree that we'd like to. And so that's one of the reasons that this event today, right now, is so important. And so we're looking for your help with that. And with that, I'll turn it over to Olivia.
Wonderful. Thank you so much, Chris. Okay, well, thank you for all of your incredible and passionate interest in our program and this webinar today. So I would like to touch on how you can help as we're launching statewide. First is spreading the word about Telebup and that we're live across the state now. You can do that by sharing the promotional materials with your community, which we'll share how to access those shortly. You can also give patients or your clients our phone number if they need help. Likewise, we are always open to if you would like to call in with a patient or a client if they're a little bit nervous about that intake call. That happens very frequently with us, that we have case managers or care managers, social workers call in to give support for that first call with the patient. Second is use us as a resource. Please integrate us into your workflow. Include our phone number on your resource sheets, as well as discharge and follow-up plans for patients or incarceral release paperwork to bridge gaps in treatment access. One thing that I will touch on is roughly 20% of our patient population is recently incarcerated when they're coming to us. And for our pilot program within King County, patients were always released with our hotline phone number. So we very frequently got a patient just released from jail at the bus stop, a little bit lost and didn't know what to do. And we're here to help them in that moment. So please feel free to include our information within paperwork like that. Or if you have a clinic closure or shortened hours, we can also take those patients to ensure they do not go without and can have bridge prescriptions for care. Similarly, please reach out to us. If you have any questions about our service or ideas about how we can partner with you to serve those in your community in a better way, we would love to hear from you. And all of our contact information will be listed next. We also have a referral partner form. This is how you can become an official referral partner for the Telebup hotline, meaning after we treat patients and initiate them on buprenorphine, you are who we would link them to ongoing MOUD care. Okay, wonderful. Next slide, please. So I will allow this slide to sit here for a moment, and all of these will also be emailed out. So please have no concern. You will have access to all of this information. First, the Telebup hotline email is the easiest way to access us. It goes to our entire team. If you have any questions or you're not sure who to contact, that is always your best bet. Second, that is my email address listed below if you have any questions about partnerships. And most importantly, the Linkage to Care Coordinator's email addresses are listed. Within your region, if you have ideas about collaboration, if you have questions, if you would just like to connect, please reach out to those Linkage to Care Coordinators, and I know they would be very excited to talk with you. Similarly, there is a QR code on the bottom right for our telebuprenorphine website. That has a plethora of information for both patients and community partners. So please check that out if you have any questions. And I believe that was put in the chat as well. Okay, next slide, please. Wonderful. Well, thank you all for listening to us today and for being here as we're opening the doors statewide. And we will move into the Q&A portion of the webinar now. Okay, so I will ask Lauren and Chris to come back on as we answer some of these questions together. Wonderful. Thank you.
Right.
The first question I will pass over to Lauren and Chris is we got the question, do you have any sense of how recent federal Medicaid changes will impact the availability of this service?
I can start on that. I think of the recent, because we are not billing insurance, our processes will not be impacted. We expect to fully be able to take care of all patients, irrespective of insurance. I do expect, though, that as more patients become underinsured or have difficulty accessing care, that we will see more patients, and we're ready for that and thinking about that internally.
Well, thank you. I'm seeing another question. What is the referral pathway if tailored or different for pregnant people who call in? Wondering if you all can touch on that along with if we treat those patients any differently for our prescribing.
Yeah. So, we generally prescribe the same medications to pregnant people as we do to non-pregnant people, with the exception of we wouldn't give them things like ibuprofen that could be as an adjunct medication that could be harmful to the pregnancy. There was a thought a while ago that pregnant people really just needed the buprenorphine monoproduct without the naloxone in it because that could be potentially dangerous. And that's just turned out not to be true. And I think the kind of newer evidence points to the fact that pregnant women are totally safe taking the combination product with buprenorphine and naloxone. We do have connections, and we are actively looking for connections, across the state for people that will care for women while they're pregnant. But we recognize that this is an incredibly, high risk time. Like the worst thing we could do would be to let something happen to that mom, right? Whether that be an overdose because she's not taking the buprenorphine, or whether that be horrible withdrawal. So we're very careful about handling that.
I know this wasn't asked, but Chris, can you talk a little bit about our work, or your work really, but the program's work that you spearhead in our adolescent population?
Yeah, so we do have, I think, a pretty good adolescent program as well, and we've had I'm not sure how many, a goodly number of kids, probably one every 6 weeks or so, that comes through the hotline that have been doing pretty well. And I think both with pregnant women, pregnant people, and adolescents, and also with the folks that are recently incarcerated, they get a little bit of more intensive outreach. Um, and so there's a lot more touch points. There's a very, very warm handoff that usually happens between the adolescents of pregnant women, or the recently incarcerated people. And with adolescents in particular, we do adjust the dose of medications just a little bit. And the law in the state of Washington is that kids over the age of 13 are allowed to be treated for substance use disorder without parental consent, and we respect that and are willing to do that. We know from science that kids do better, and it just sort of makes sense. The kids do better if their parents are involved and supportive. And so we always do encourage a conversation there, and are happy to facilitate that, on the patient's behalf if that's what they want. Yeah.
Great. Thank you, Chris. Another question I'm seeing: if a patient does not identify a preferred pharmacy, will hotline staff be able to ensure the prescription is sent to a pharmacy that contracts with their insurance? Yes, we will. What I will add to that is we often see the biggest barriers for our patients at the pharmacy. This is due to a variety of reasons. Sometimes the pharmacy is out of stock of buprenorphine. Sometimes they won't accept one of the voucher programs we're sending to lower that prescription cost. I can ensure to everyone on this webinar is that our Linkage to Care team goes above and beyond to ensure that all pharmacy barriers are addressed and removed for patients if available. If we find that a patient did have a barrier at a pharmacy, we will never just start sending them on the road to other pharmacies. We will start calling around and doing our due diligence to ensure that they can serve them before sending them elsewhere. But we can absolutely ensure that they do contract with their insurance. I'm also seeing a question from Elizabeth. This is a great question. I wonder if there is any way to provide clients with direct or real-time assistance with applying for Apple Health. Has this been explored? Elizabeth, thank you for this question. I think it has not been explored yet, and that is due to a couple reasons. One, our hotline is incredibly busy right now, and those intake calls can often take upwards of 30, 45 minutes with patients on occasion, along with the provider calls after. So with our current staffing, we have not had the bandwidth to have these intensive calls with patients to set up the insurance for them. However, as our staff is training and onboarding over the next few months, I think that is something that we would love to explore with you and HCA of what the opportunities are there. But in our current bandwidth, we cannot hop on and sign patients up for insurance. let's see. There's another question from Janet. And Chris, I saw that you answered that, but just wanted to see if you all wanted to address that live. Are there medications available that can also assist with xylazine withdrawal? Fent and Trink frequently occur together.
Yeah, so I was just sorry, I probably had my dumb typing face on while I was doing that, but yeah, so we do use clonidine as part of our sort of routine withdrawal management, symptom management kind of adjunct medication, which is what you would treat tranq withdrawal with. We haven't seen as much, according to sort of the ADAI's kind of drug sampling network and the medical examiner, we haven't seen as much tranq recently. And so I'm hopeful that that's kind of going away. But everybody gets offered, almost everybody, I think, gets offered clonidine as one of the medications that they can use to help manage their withdrawal symptoms in addition to their buprenorphine. So, so the answer to that, I'm not sure that we've been how much tranq we've been treating, but we've been giving them the medicine they need for it.
Amazing. Thank you, Chris. Another question I'm seeing, will the linkage to care coordinators connect people to case management teams through their insurance providers to support ongoing needs, particularly through Apple Health? That is not something that we are doing currently, but is something that we can look into through this phase of expansion. And then we have a great question that says, have you all had any incidents of precipitated withdrawal with people starting on buprenorphine? And if so, how have you all addressed this via telehealth?
I can start with that one, and Chris, you can jump in. We've had a few. It's hard to say if it's precipitated withdrawal or worsening withdrawal. And I think the treatment of that always starts at the very beginning with a good conversation with the patient about expectations and how to sort of think about this. Most importantly, we are a phone call away. So if patients are having adverse events, precipitated withdrawal, worsening withdrawal, don't know what to do, they can always call and get a doctor very quickly. With the instructions that we provide all of our patients on the phone, we talk about sort of preparing to start. And as Chris mentioned, being able to get into pretty significant withdrawal before they start the buprenorphine. And that is to help them mitigate against precipitated withdrawal. We sort of counsel them at the beginning that if they take medication and they feel worse, that they should take more. That is so counterintuitive to any other medication that we talk to patients about. So we sort of talk about that at the beginning so that they know that if they feel worse, they actually need to take more. And then the thing that we can do also is help refer patients to the emergency department. If they're on the phone with, if they're having an adverse event, if things are not going well in their environment, and we're talking to them by telehealth, the doc on the phone is an emergency doc. And so wherever they are, they'll have a good sense of whether they really need the emergency department or not, and would help facilitate a warm handoff to the emergency department of their choice in their region.
Great.
Yeah. And I would just say, I mean, I can only think of one person that we think probably really had precipitated withdrawal, and that person had been using methadone, I think, that we didn't know about. And that is important because methadone is in your body for so long that we try to really drill down on, how long has it been since you've used methadone. And that was tough. I mean, we were having multiple phone calls a day, calling in this medicine and that medicine and checking on and see how they did. I think eventually they did end up, we ended up calling the emergency room and say, hey, this person's coming in and here's their story and here's what we think you should do. But it is, I mean, we've had, 1,300 patients, I think now. And so it's pretty rare. But yeah, we have, we do our best to provide as much wraparound support for that patient in their community as we can.
Yeah, thank you both. The one thing that I will add, which I find unique, at least with using telehealth in my personal life, is when you go to a telehealth provider, if you have any questions or issues after that visit, it can be really hard to actually get in touch with the provider you spoke to. And that's how Telebup is really unique. You can call back that same day and you can be connected with the provider that treated you very quickly in order to coach you through any questions or concerns you have. Another question that I saw come through is, can frontline workers and outreach workers do a test call so we can better understand and explain the process to our participants or clients? Absolutely. And I encourage that. We often do get calls come in just to see what we're about and how it works, and absolutely feel free to do so. The next questions, I'm going to answer a group of questions, and it's about our promotional materials. So I see some questions coming in with that. We will have promotional materials. A form will be sent out after this webinar where you can all order posters, wallet cards, and stickers. That is just the start of our promotional materials. We will be launching a brand new logo later this year with a slew of promotional materials and hopefully a social media toolkit to go along with it. But you can start with those resources. Our QR code for our website, of course, does have the phone number to call, and we'll make sure that's sent out in the information after this. And I did see one last question about multiple languages. My apologies. I should have mentioned earlier, we have 24/7 translation services through the Telebupe hotline, which has worked very successful in the past for patients. And yes, we will have printed materials that you can order. Okay, wonderful. Chris, just because I think more folks would be interested in it, do you want to touch on how this partners or looks like with Scala Northwest, as that is a big part of your work?
Sure. Yeah, I'd love to talk. I mean, I love to talk about Scala Northwest. That is my other favorite thing to do. So Scala Northwest is, I think this partners really well with Scala Northwest, right? The hotline is really meant to be a patient-facing thing. We want patients to call. This is, providers can also call, but we are not going to prescribe to providers. It's really set up for patients, in their kind of moment of need. Whereas Scala Northwest is really a provider-facing thing. And so it provides protocols and things that basically everything providers need, right? Like diagnostic criteria, protocols, patient handouts, discharge information, and a link to the 24/7 physician consult line at UW or psychiatric consult line at UW for people that need that. And so Scala, I think, is a great resource, and we use their protocols on the hotline, and vice versa. We really kind of co-developed those so that they should be pretty well harmonized. But I would say Scala is really more for EMS providers and primary care docs and inpatient docs and EM, emergency medicine people, whereas the hotline that we're talking about today is really meant for patients.
Great. Thank you so much for that, Chris. I see another question here. Notice that you're naming ACHs to name designated regions. Are there other ways the Washington Buprenorphine program is working with ACHs in their community care hubs? That's a wonderful question. The linkage to care coordinators absolutely will, and that is one of their goals, to integrate within the community care hubs and the ACH region that they work in. I believe in partnership with Department of Health, we'll be presenting to the ACH leaders this spring. Okay, wonderful. And then I saw a question from Chris. Is this being connected to RTCM in carceral facilities? Great question, Chris. We are in the process of connecting with more incarceral facilities throughout the state, and happy to connect with anyone that has a direct connection or resource there. But a lot of that is actively being outreached in partnership with Department of Health over these next few months as we launch, to ensure that everyone has our information and we know how to partner well for these patients. And then one last question that I think I saw earlier was regarding EMS providers and how they can access. Chris and Lauren, would you like to touch on that one?
Yeah, I was actually just typing the answer to that in the chat because I think I did something to make that one go away. Sorry, my Zoom skills need some polishing. So we have, when EMS calls, so if EMS is with a patient and they call the hotline, the first thing here is this kind of phone tree option, and we have a special option just for EMS providers that will make sure that they get to the front of the line and they don't have to wait, because we know they're anxious to get back in service as soon as possible. I think at that point, it really depends on if they're calling from the EMS. Like if the patient has their own phone, then I think the EMS can stay there to help the patient kind of give their demographic information and make sure that the hotline can get back in touch with the patient. Um, if the patient's calling from one of the EMS providers' phone, then the whole call does take a little while, right? We have to do the intake and then get the doctor call back, and we'll do that right away. It'll be the first call. And then the encounter takes 15 or 20 minutes. So I know I recognize that can be a long time for EMS to be kind of sidelined. But I just want to be sort of, I also don't want to set false expectations or so if you're using an EMS phone to call the hotline for the patient because they don't have another phone, that's amazing. And we appreciate your advocacy and compassion for the patient. But it is going to take a little while, and we will do everything we can to get you back in service as fast as possible. I don't know, Lauren, if you have other.
Yeah, I can add to that we've trialed all this with Seattle Medic One as well as King County EMS in our pilot. Seattle Medic One has a paramedicine unit they call Health 99, a post-overdose response team that has the time, the mission, the personnel to sit with the patient for a long time and really be the conduit for all of this care. And they do a really impressive, amazing job, and they can help facilitate the phone call. They can also help facilitate getting the medications, and they can do follow-up calls. King County EMS has done a really great job of identifying patients and having a lot of our promotional materials at the ready. So especially post-overdose patient that gets reversed with Narcan may not be ready for a treatment discussion. That can be a long time. But the medics can provide these promotional materials and say, here, when you're ready, call this number. They can give you some information. They can get you set up with treatment. And we've had quite a few patients take us up on that route. So we recognize that Chris said that being in EMS, you may not have the time to sit there with people and explain treatment and be the advocate for the patient for this specific thing. As a good public health resource, you're sort of providing public health for that whole community. But having those promotional materials at the ready can be really helpful and a way to provide some information to these people in your community that you're seeing post-overdose or that have OUD.
Amazing. Thank you both. We've got a couple other really good questions that have come in. One was, I may have missed it, but is this a temporary script or is this paired with ongoing care? So we do a short-term prescription. It is typically a length of 2 weeks. We can do up to 3 prescriptions in 3 months, but we are not a long-term care model. So really the reason why Telebupe works is so much of our efforts are focused in linking these patients into ongoing care. But we are here to be an open door the moment that they are ready to seek care for their opioid use disorder. I also saw a really great, thoughtful question about translation access. So in my experience, folks requiring translation to access services might experience additional hesitation when accessing services due to a translator's lack of familiarity with the slang or unique terminology used by currently an active use community. Has the translation service been prepped or have experience translating for this community? That's a wonderful question. The translation services that we use are utilized throughout all of UW Medicine. So they are trained in handling these cases with patients and being very sensitive around this topic. However, what I'll also say is that our providers or linkage to care coordinators, when calling in translation services, are always briefing them and discussing why we're doing this call today and giving a little bit of background about that patient and the care that we deliver to ensure that we feel confident that they are meeting all of the standards for care for Telebupe as well for these patients. Okay. Wonderful. I will say I saw a lot of questions in the chat about resources after. I know we're closing out. Thank you for all of your incredibly thoughtful questions and comments. We will be sending out resources after this for the slides, for the order form for promotional materials. We'll have a link if you would like to request a presentation from the Telebupe team, as well as our website resources. So thank you all on behalf of the entire Telebupe team. Thank you for giving us this opportunity today and for welcoming us into your spaces to offer this throughout the state. And I will pass it back over to our Department of Health group.
Wonderful. Oh my gosh, all those reactions are making my heart flutter. Thank you so much to our panelists, all of you for being here today and sharing this incredible information. There was some great comments in the chat that were really heartfelt just about this great work and how this is going to impact communities. And I am just thrilled to be a part of this and excited to see how this statewide launch goes. I will drop my email in the chat in case anyone has questions logistically about the webinar. I will be sending out, like Olivia said, all of this information once our recording is ready, the links to all of the order forms and the partner referral form. But in the meantime, if you have any logistical questions about the program or the webinar, please feel free to reach out to me or Olivia. And again, I just want to say thank you to all of you for being here today. This was a great turnout and we are so excited for this to move forward. So happy Monday and thanks to everyone.